So precision medicine, which is also known as stratified medicine, is taking the trial and error out of prescribing and making prescribing much more targeted to the individual. And by that I mean, if I was treating 20 patients with psoriasis, I would not know just by looking at them who was going to respond very well to a drug, who was not going to respond, and who perhaps would have side effects. Stratified medicine is the ability to target the drug to the patient so they get the best response and minimal side effects. So my role in precision or stratified medicine is twofold. On a personal level, one of my major research interests, and has been for many years, is the skin disease psoriasis. And I currently lead a Medical Research Council Stratified Medicine Consortium called SORT, that's P-S-O-R-T, Psoriasis Stratification to Optimize Relevant Therapy, which is a nationwide consortium of clinicians and academics, scientists, and industry, 10 industry partners, and the patient organisation, the Psoriasis Association in the UK, bringing together all those group of individuals to use clinical, genetic and immune biomarkers to try and work out which patient is going to respond best to which biologic therapy. The secret for precision medicine is bringing together all the expertise that can be focused on this problem. So you'll be getting information from genetics, you'll be getting information from immunology, information from clinicians, and bringing in statisticians and what are known as machine learners who work in health informatics who can discern patterns within huge data sets. We need to have the ability, which we do have now, to handle very large data sets, bringing together all these disparate pieces of information. And we are in a position to do that. So the idea was, it's not just purely research, it's actually implementation of the very best research into clinical practice, and also it's streamlining clinical services. So it's a whole new way of thinking about management of health and health research in a conurbation. Something new for the UK, but not new on a global scale, that is already happening in the United States and elsewhere for several years. And of course it should have happened many years ago. I was the research director for the Academic Health Science Centre to begin with, working closely with Alan North, who was the director. And then when he stepped down, I became the director of the Academic Health Science Centre for a short period. And then we went through a redesignation process, and MASC was redesignated in 2013. There was one additional Academic Health Science Centre brought in at that time, and that was from Oxford. Well, Manchester, in my view, has always punched beneath its weight. It's a big city with a diverse population with significant health inequality. So for our city, we should be doing that. We have large NHS trusts with tremendous expertise, some of the experts in their specialties, not just in the UK but in the world. And we have one of the largest university with a very well respected clinical and life science research power. Well, the ultimate endpoint is that in 20 years' time, if you go to see your doctor, it will be that sort of Star Trek approach, that they will be able to, by using demographic clinical information, plus maybe a small skin biopsy, I'm talking about psoriasis now, small skin biopsy, maybe a blood test, put together all that information and say, okay, you have psoriasis type A, which means that the very best treatment for you, not just in the short term, but in the long term, is going to be drug X. In clinical trials, of course, no industry, whether it be Novartis or whoever else, can do their clinical trials without access to patients. So the hospitals in Manchester have those patients. They have them well characterised. There's good cohorts of those patients who, for the most part, are interested in taking part in clinical trials. So I think that's very important. The second is with precision medicine. It has to be, from the get-go, a collaborative effort between academia and industry, because whatever we find, we've got to commercialise it. If you come up with a new diagnostic or new algorithm, a new stratifier for identifying which patient's going to respond best, to bring that into clinical care has to be done with industry, so the diagnostic companies will be involved. But of course, also industry partners, the pharmaceutical company partners, have got to be involved because we're going to be doing the research on their drugs. So my view is that it's a win-win situation.